Thank you all for joining us. Our webinar will be beginning shortly. I want to take a moment to let you guys know about a few of our upcoming courses. Tomorrow, Thursday, April 2nd at 12 p.m. Pacific, we will be hosting Workers in the Service Industry during the coronavirus pandemic in Spanish. You can sign up for that on our website, as well as view the English version that we hosted on Monday. Next Tuesday, April 7th at 12 p.m. Pacific, will be Creative Use of Direct Reading Instruments with Dr. Thomas Peters, in partnership with the Heartland Center for Occupational Health and Safety as a part of our monthly NIOSH Education and Research Center Industrial Hygiene Series. Wednesday, April 22nd at 12 p.m. Pacific, we will partner with Central Appalachian Regional ERC for the webinar Lean Ergonomics, It's an Efficiency Issue with Steve Davis and Luther Cottrell from the University of Kentucky's True Lean program. For more events and information, visit coeh.berkeley.edu/about-CE. Thank you again for joining us. Our webinar will be beginning shortly. On behalf of the Center for Occupational and Environmental Health, I would like to welcome you to our webinar, The Impact of Safe Patient Handling Legislation in California by Dr. Soo-Jeong Lee. A few housekeeping items first. You will be muted during this presentation. If you would like to ask a question, please enter it into the online chat or Q&A box. We will save time at the end of the presentation to address all questions. This presentation is being recorded and will be made available on the Center for Occupational and Environmental Health YouTube page and on our website, coeh.berkeley.edu/about-CE. All participants who logged in with their registration email will receive a link to their recording and an evaluation form that will qualify participants for a certificate of completion worth 1 continuing education contact hour. At this time, we are pleased to welcome our presenter. Soo-Jeong Lee is an associate professor in the Department of Community Health Systems in the School of Nursing at the University of California, San Francisco. Her research interest focuses on the prevention of work-related injuries and illnesses and evaluation of occupational risk factors and work environment. She has been the principal investigator of federally funded research projects focusing on musculoskeletal disorders and safe work practices among healthcare workers, and evaluation of the impact of California's safe patient handling legislation. Thank you for joining us.
Thanks for the introduction, and thanks for the opportunity to talk about my research through this webinar. I want to start with saying that protecting the health and safety of healthcare workers is essential for worker individuals and also critical to saving lives, safety of patients, and providing quality care. Provision of a proper PPE is a top priority for protecting workers from exposure and infection. My presentation today focuses on safe patient handling for musculoskeletal injury prevention. I have no disclosure. This is the outline of my presentation. First, I'll be talking about some statistics and data on musculoskeletal disorders among healthcare workers, interventions, and safe patient handling legislation and regulation. And then I'll be presenting some findings from my research, which was conducted to assess the impact of California's safe patient handling legislation. So this is learning objectives. You'll be able to describe California's safe patient handling legislation and regulation, identify positive impact of the law, discuss continuing challenges in patient handling and work environment. Healthcare workers are at high risk of musculoskeletal disorders. This is a well-known fact. Nursing workers have been listed among top occupations with the most cases of MSDs resulting in lost work time. RNs, registered nurses, have been ranked 5th to 7th, and nursing assistants have been ranked 1st or 2nd. So in this slide, you can see the data for the past 20 years. The orange line is for nursing assistants. The blue line is for RNs. Nursing assistants case numbers continue to be at the top, but the numbers have decreased over time quite a lot, more than 60%. However, for RNs, there is not much change in the case count. In addition, the median lost work time has increased from 6 to 9 days for RNs and from 5 to 7 days for nursing assistants, which suggests increased injury severity. So in terms of MSD prevalence, Davis and Kotowski published a systematic review paper and provided very comprehensive data on MSDs in nursing workers. This is a busy slide. You can see prevalence using various measures by body region, with the low back and shoulders being the most commonly affected. I'm not going to go over the details in the interest of time, but you can refer to the literature later. For healthcare workers, patient handling is the major risk factor, accounting for large proportions of MSDs and workers' compensation claims and costs. According to the NIOSH, the maximum acceptable weight for manual patient handling is 35 pounds. However, in reality, most patients are far heavier than this limit. Data on the right side is from a survey that I conducted in 2013. 283 nurses answered to this question. And you can see many nurses work with patients over 200 pounds. And the maximum weight goes up to 840 pounds. This can get worse with the increasing obesity among the general population. The NIOSH conducts surveillance using Occupational Health Safety Network. They published a report on occupational traumatic injuries among healthcare workers. The data was collected from 112 facilities. In 2012 to 2014, there were about 4,700 injuries associated with patient handling and movement. The incident rate was over 11 per 10,000 workers per month. As you can see on the right side, most injuries occurred in inpatient adult units. Repositioning was the most common activity causing the injury. Most injuries occurred when lifting equipment was not used. And the incident rate of these injuries was 5 times higher than injuries when equipment was used. Another study provides more detailed information on tests associated with patient handling injuries. Pompey and her colleagues analyzed data from the Duke healthcare system. And lifting was the most common cause of injury. Assisting with the patient mobility was the next common cause. Transferring, pulling a patient in bed, repositioning. About 6% were from catching patients to prevent from falling. The authors noted that the injuries resulting from lifting or transferring, they may be prevented by the use of lift equipment. On the other hand, injuries from other tasks, the repositioning or catching from prevent falling, pulling a patient in bed, assisting mobility, they may not be prevented by lift devices. So effective safe patient handling programs need a comprehensive approach. The provision of equipment is a crucial component, but also management commitment, worker involvement, safety committee, policy, risk assessment, training, surveillance, and evaluation are essential components. This is a meta-analysis study results on the effectiveness of intervention programs, which included the lift equipment and lift teams. Most studies found significant reductions of injury risk by interventions. So you can see the data on the figures. Overall, these programs reduced injury risk by 56%. Which shown these interventions are effective. This slide is from an OSHA publication, and safe patient handling programs are reported to be cost effective. Return on investment was shown within 1 to 4 years. So now I talk about legislation. Since 2005, 11 states have enacted safe patient handling laws. Texas was the first state, and California passed the law in 2011. Some other states also made efforts without success. Federal bills were introduced 5 times, most recently in 2015, but not yet passed. In California, it took 7 years to pass the Safe Patient Handling Bill. The bill was finally signed by Governor Jerry Brown in 2011, and the law became effective in 2012. This law applies only to general acute care hospitals, so excluding some hospitals in government facility. It requires employers to implement safe patient handling programs, including maintaining a policy, replace manual patient handling with lift equipment, provide trained lift teams or other support staff, provide training, RN's responsibility as the care coordinator, and also address employees' right to refuse unsafe patient handling. So after the passage of the law, OSHA developed detailed regulations to implement the law and released the regulations in 2014. So to my knowledge, California is the only state that has OSHA regulations on safe patient handling legislation, safe patient handling. A hospital's plan must include components of hazard identification, injury investigation, hazard correction, communication, evaluation, and training. And this plan must be in writing and available to employees at all times. The regulation also states the availability and use of sufficient staff for safe patient handling. So we conducted several studies to assess the impact of California's safe patient handling legislation using multiple methodology. So we analyzed California's workers' compensation data to examine the changes in the magnitude and instance of patient handling injury claims at the state level. We also conducted statewide surveys of nurses to identify changes experienced by workers. We also conducted a focus group study to understand perceptions and experience from worker perspectives in depth. I'll be presenting workers' compensation data analysis first, and then survey and focus group studies together. So for workers' compensation data, the source was California Workers' Compensation Information System. We obtained first reports of injury data from 2007 to 2016. The first 5 years are for the pre-legislation period. The latter 5 years are for the post-legislation period. So we compared the data and also look at the trend. This slide shows the overview of the data analysis. We identified healthcare workers and then cases in general acute care hospitals. Among other cases, we identified cases in nursing and residential care facilities as a comparison group. Among these groups, we analyzed data for nursing worker cases. In terms of injury type, we identified MSD cases, and then we classified them into patient handling injury and other. So we looked at patient handling injuries within MSDs. I want to briefly talk about how we identified healthcare workers. So this is a little bit busy slide. So we defined healthcare workers as those employed in the healthcare industry, regardless of their job title. The workers' compensation, class codes, and industry codes are the primary information for healthcare case identification. In addition, we used employer name, occupation description, and injury description for case identification. So this was because for government cases in general, healthcare industry codes are not used in the workers' comp system. So we needed a further approach. Also, there are errors and missing information in class and industry codes. So we used all this multiple information for case identification. So in 2007 to 2016, there were about 5.8 million claims in California. Among these, about 17% were initially extracted as a possible healthcare worker cases for our data review. And then we developed case coding methods by combining multiple information. And then we classified the cases into definite, probable, possible, not likely, and no categories. And in the final data analysis, we included definite and probable cases. And then these were classified as general acute care hospital, nursing and resident care facility, and other. For occupation, we identified nursing workers using occupation description. Initially, we wanted to look at nurses and nursing assistants separately, but often their job titles were not distinguishable by the description. So nursing occupations were combined into one occupation group. MSD claims were defined using the combination of nature of injury, cause of injury, and part of the body injured. So this combination is the method used by the California Department of Public Health. In this study, we made some modifications. For example, the cause of injury code 74 is struck or injured by fellow worker, patient, or another person. And this code is not included in the original MSD case definition. However, we added this code because our study is about patient handling injuries. And so this reviewing this data can be relevant for our study. So we use this code combining with specific injury nature, such as a strain, also specific injury description, including terms such as transferring. So combining this information, we included cases with this code. For patient handling injuries, there is no specific code. So the cases were identified by reviewing the narrative of injury description. So we developed various search terms and combinations of words to identify patient handling injury cases. So some examples are presented in this slide. So this slide shows the number of MSD claims among healthcare workers in 2007 to 2016. So we identified over 300,000 MSD claims among healthcare workers, and this accounted for about 40% of healthcare worker claims. Of these, 20% of these MSD claims, 28% were identified as patient handling injuries. So in this graph, orange bars indicate patient handling injuries. And then you can see the annual number of patient handling injuries has decreased since 2012, whereas other injuries didn't show that pattern. So looking at patient handling injury claims by setting, the bars on the left is hospital, bars on the right is nursing and residential care. As you can see, hospital PHI claims show a clear trend of reductions since 2012. During the post-legislation period, the cases decreased by about 15% compared to the pre-legislation period. In comparison, in nursing and residential care settings, cases increased about 10% during the post-legislation period, particularly in 2015 and 2016. So this was interesting since this is the period after the OSHA regulation was released. However, this law and regulation applies to only hospitals. So looking at PHI claims among nursing workers, it showed the same pattern. So the PHI claims by nursing workers showed a clear decreasing trend in hospitals. About 19% decreased during the post-legislation period. In comparison, PHI cases increased in nursing and residential care settings. This slide shows claim rates. The blue lines present MSD claims. The gray lines present non-MSD claims. The orange lines present PHI claims, patient handling injury claims, and the yellow lines present non-PHI claims. So for trend analysis, I included data only for 6 years from 2011 to 2016. So in hospitals, in the center figure, MSD claims and PHI claims had statistically significant reductions over time. So there was a significant reductions in the rate over time between PHI and non-PHI claims, and also between MSD and non-MSD claims. So in addition, comparing PHI claims between hospital and nursing and residential care, the rate change over time was also significantly different. Such patterns, so we also look at the rate among nursing workers, and this pattern were more clear in data for nursing workers. So you can see significant reductions of PHI claims and MS claims among the nursing workers in hospitals, but it was not observed in nursing and residential care facilities. So all these findings support safe patient handling legislation applied to hospital settings was effective to reduce PHI, patient handling injuries. This slide shows MSD and PHI claims by body part among hospital workers. The MS data on the top, patient handling injury data are on the bottom. As you can see, for MSD claims, upper extremity cases were the most common. On the other hand, for PHI claims, low back injury was the most common. Looking at the trend of PHI claims, in general, cases decreased in most body parts, and reductions was more apparent in upper extremities, trunk, and lower back. This slide shows a snapshot of demographic characteristics of patient handling injury cases in hospital workers. About 70% were nursing workers, 80% were female, about 55% were ages between 30 and 49, and about half had job tenures more than 5 years. Next, I will talk about findings from our California RN surveys and focus group study together. So we conducted 2 surveys in 2013 and 2016. The first survey was conducted 1 year after the law took effect. It takes time to implement the programs, so I believe it served well as the baseline in an early phase of the law implementation. The survey samples were selected from California BRN list. In 2013, we selected 2,000 RNs with active license. And in 2016, we increased the sample size to 3,000 because of the low response rate in the previous survey and the resulted small sample size. We had only mailing address information, so we used postal survey as the primary method. We also created an online survey site and gave the option of responding at the online site. Unfortunately, response rates were low, with 26% in 2013 and 20% in 2016. So in this study comparing 2013 and 2016 data, we included only hospital nurses who were employed at least 3 months and performed direct care or patient handling. So this slide shows sample characteristics of the study samples. Between the 2013 and 2016 samples, there were no significant difference in demographic and job characteristics, except for hospital size. So in the 2016 sample, nurses employed in small hospitals were more represented. For the focus group study, we tried to recruit participants from different hospitals in different areas. We conducted 3 groups, including 21 participants. It was a small number, but they were from 12 different hospitals in 8 different counties. Most participants were med-surg or ICU nurses. The sample also included 2 patient handling specialists. In the survey, we asked about awareness and perceptions of the safe patient handling law. In 2016, more nurses were aware of the law, about 75%. In 2016, 43% answered the law was very or somewhat effective for worker protection. So these are several quotes from focus group participants on the knowledge and perception about the law. So one participant commented, Without the legislation and regulations, they wouldn't have what they have now. Another participant mentioned empowerment. They can speak to their right and they can refuse unsafe tasks. There were also several participants who were not aware of the law. So regarding safe patient handling policies and programs in their workplace, 1/3 answered it was excellent or very good. Another third answered fair or poor. In 2016, about 2/3 answered they noticed the changes in their hospital policy and programs for safe patient handling. And 87% answered their hospital had a safe patient handling policy, which increased about 64% from 2013. So in focus groups, some participants were aware of a safe patient handling policy in their hospitals. And one participant said she participated in the process. Another participant said she never looked at the policy. There were also positive comments about Safe Patient Handling Committee on the openness to various staff. On the other hand, some participants noted the lack of input by nursing staff in the committee and also limited support from management. Training. The proportions of those who received the training in the past year increased in 2016. However, annual training is required by the law, and almost 30% did not receive the training in the past year. So in focus groups, most participants mentioned there were increased more regular training. But participants also stated it depended shift by shift. Particularly, limited training was noted for night shift workers. One participant said she hasn't had a training in 3 years, and also gaps between management and staff were noted. As for lift teams, there was a slight increase in 2016. Looking at the data by hospital size, I did not present, but we looked at the data by hospital size for lift teams. And lift teams were more available among nurses in large hospitals. However, the availability of lift teams was significantly increased among nurses in small hospitals in 2016. In terms of lift equipment, the availability was significantly increased in 2016, and 80% had lifts on their unit. In terms of lift type, you can see the proportion of nurses with the ceiling lifts doubled in 2016. So we also asked about changes in lift availability and lift use over the past 4 years. And so 61% answered lift availability was improved. However, only 39% reported they used it more frequently, which suggests continuing changes in lift use. So I compared the ceiling lifts and floor lifts because ceiling lifts can have advantages over floor lifts because it can be readily available in the patient room. So comparing lift use by lift type, lift use was significantly higher among nurses with ceiling lifts. So there is benefits by ceiling lifts. In addition, nurses with ceiling lifts had more positive perceptions about lifts regarding many aspects, worker safety, patient safety and comfort, ease of use, access, and storing. However, regarding concerns on time burden, there was no difference between ceiling lifts and floor lifts, which suggests there is a need for an improvement. So looking at the focus group data, lift teams were perceived as a valuable resource by many nurses, but the limited availability was mentioned as a main problem. Some nurses mentioned also their hospital removed the lift teams and replaced with the equipment. So we included lifting staff in the participant, and they noted challenges from inadequate staffing. So regarding lift equipment, all participants stated they had more equipment available, but also noted barriers to using the lift, such as insufficient competency, time burden, or situations where lift use is not appropriate. We asked about injury in the past year. There was we found no reductions in the injury incidence. And in 2016, 16% answered they experienced an injury from patient handling. So we also asked about work-related symptoms, which was caused or worsened by work. So the prevalence of any symptoms was increased in all body regions in 2016. However, when you look at the symptoms, the major symptoms, which we defined with greater intensity, duration, and frequency, the prevalence was lower in all body parts. So so there was improvement in terms of reducing more major symptoms. And the findings of prevalence reductions were statistically significant, controlling for multiple variables. However, the reduction for shoulders were not statistically significant. So in focus groups, some participants talked about their own injury experience and also co-workers on modified duty. And one participant noted they received weekly reports and they received the information what could have been done differently to prevent the injury together. Interestingly, some participants noted they think there is potential change in injury patterns, such as increase of shoulder or neck injuries because they use ceiling lifts more. So this was an interesting comment for me. So I look at the workers' comp data for shoulders. So the reduction of patient handling injury claims in shoulders on the top, so that was less apparent than other body part. In addition, compared to the pre-legislation period, the number of PHI claims were higher during the post-legislation period. This is more obvious for MSD claims. So the number increased during the post-legislation period. And also there was no reduction during the post-legislation period. So this was interesting observation and interesting comment. So further research is needed to investigate this question. We asked about nurses' perceptions about injury risk. And only 30% perceived decreased risk from patient handling. And more nurses perceived the risk as increased. So this finding suggests nurses continue to experience challenges in performing patient handling safely. There was many comments about staffing in the focus groups, and insufficient staffing and difficulty in getting help emerged as the major barrier for safe practice and lift use. Also, increased workload with the changing care environment and increased requirements was also identified as a challenge. So we also look at the survey data and it showed consistent results. So as you can see in the below table, we found physical workload and job demand were significantly higher among the 2016 sample. So there was some increase in terms of workload. Lastly, some participants commented positive changes in safety culture, using more equipment, engaging in more safe work practices. On the other hand, one notable finding was the perception about management. So several participants noted management attitudes became more punitive and individual workers were blamed for injury if equipment was not used. So this was some unexpected, interesting finding. So this slide lists the themes from the focus group and summarize the awareness of safe patient law and policy in the workplace, increased but insufficient training on safe patient handling, increased provision of lift equipment, but it can be a partial solution. Increased lift equipment use with the continuing barriers, changes in the use of lift teams, insufficient staffing and difficulty securing assistance from staff, positive impact on safety practices and culture with the empowerment, punitive management attitudes and increased blaming of individuals for injury, increased workload and continuing injury risk. So in summary, we observed significant reductions of MSD and PHI claims during the post-legislation period, particularly in upper extremities, lower back, and trunk among California hospital workers. So we found significant reductions of work-related major symptoms in low back, neck, and hand and wrist reported by nurses. We also found increased awareness of safe patient law and policy among nurses and improvements in hospital safe patient handling policies and programs. However, there was no significant improvement in lift use. We also found continuing challenges and barriers for safe patient handling practices and injury prevention. I'd like to acknowledge the funding sources for my research and also all people who contributed to these projects. Thank you.
Thank you so much for the presentation. At this time, if anybody does have any other questions, if you want to add them to the Q&A box down below or into the chat box, I will start asking them to her now. So we do have a few questions already and a couple statements. The first question is, does California's safe patient handling law also apply to VA hospitals based in California, given that the VA is a federal entity?
Oh, that's a good question. To my knowledge, California law applies to I mean, to my knowledge, it does not apply federal facilities, but I need to get back to the information. Does anyone know the correct answer?
Let's see if anybody responds. If anybody does have an answer to that question, if you want to put it into the chat box, and I will come back to that in a moment. The next question is, in healthcare facilities where SPH is not required or regulated, what have you seen those facilities doing to minimize injuries?
Oh, so the California the law applies to general acute care hospitals, and it does not include the hospitals in the correctional facilities, and also development, the facilities run by Department of Development and Services. And so actually I did not ask that information about, I did not collect the information for specific to those groups. So I do not have answer for that question for those facilities in those different groups.
Okay, thank you. Let me go back up top. Okay, so one of the first questions was a two-part question. One, with Texas being an early adopter of SPH legislation, have they shared their amendments or lessons learned during their years of enforcement over the last 15 years? And also, do you know of any other states that have implemented SPH legislation at a state level?
Yes, in the slide, 11 states enacted safe patient handling legislation. Texas was the first state, but to my knowledge, there is no information or specific data at the state level for Texas. However, Washington states, they conducted a study to investigate the impact of the patient handling legislation, and also to investigate the implementation of the legislation. And they found positive changes and reductions of workers' compensation the rates after the legislation. So Washington state provided good information. I think New York State, they passed the legislation in 2014, and I attended the conference, APH conference this year, and the researcher in New York State, they actually presented about some positive changes in New York State.
Great, thank you. Okay, so we have a few more questions. Is any safe handling legislation under development for long-term care facilities in California, and is there a need for it?
So definitely, as you saw in the data, the risk is higher among nursing homes or long-term care facilities. So definitely there is a need. And some states actually, their legislation applies to nursing home or long-term care facilities. However, the California law does not apply to nursing home or nursing care facilities. So definitely there is a need, and I want to see it expanded to nursing home and long-term care facilities.
Okay, great. So this is a two-part. This is one of the participants had a statement, and then someone else had a question to build upon that. So the participant said that they wish that there was a patient mobility task variable that was being uniformly collected as an important component of injury reduction strategies. That would capture exactly what's being done at the time of the injury, helping to focus on the match between task and equipment design. For example, she is looking intensely at toileting relating injuries, given the unique properties of toileting dependency. Interviewing SPHM professionals, toileting is viewed as a persistent problem for falls, but is not well documented in SPHM. It would be great if injury data included ambulating patient to the bathroom versus lifting patients to transport to the bathroom versus assisting patient to transfer onto commode. Toileting has long been recognized as the most taxing of SPHM tasks, with frustration commonly expressed with the staff's failure to use SPHM equipment. Perhaps the equipment commonly available is not suited to the toileting need. And the second question to that was just, has California developed any resources or repositories of strategies for some of these specific high-risk tasks?
Yes, I think that's a good point. And I think there is need to analyze the data or invest the risk by specific task. And actually, in the literature, some studies look at the risk by specific tasks. And so I think the information is available in the literature, but in my study, I did not look at the rates or cases by specific tasks.
Great, thank you. Okay. So we have time for quite a few more questions. If anybody has any more, please write them into the Q&A box. One question is, did the focus group identify any ways to increase lift equipment other than increasing staffing?
So that's a good question, yeah. So I think many people mentioned about staffing, and the staffing has been a huge issue for any type of problems. But some focus group workers, they mentioned about some, they are not competent in using the lifting devices. So definitely training can help to increase the lifting equipment use. So definitely we found there were more training after the law became effective. However, there is more the strategy to provide more effective training for workers.
Okay, thank you. And let's see, we did have one participant say that they believe the federal entities are not regulated by the state, for example, the VA hospitals. So thank you for that.
Yeah, good. Yeah, I also thought that's the case, but thank you for the confirmation.
Another participant wrote, you mentioned the use of SPHM cannot prevent injuries that occur from preventing a fall. It seems that if the patient is properly assessed and the correct equipment is chosen based on the assessment, then it could prevent these injuries. What are your thoughts on that?
Actually, that is the comment from the authors for the research, the study. So definitely there are various types of lifting equipment and lifting the assisted devices. So I think some devices can help to reduce risk for those ambulation. So I think definitely there is improvement in the technology and equipment. So I think it can help partially, but I think still, not all injuries can be prevented by the lift equipment. So there are additional components to prevent injuries.
One of the participants also wrote that it's just an observation that it seems as if the equipment should be redesigned to increase usability.
Yeah, I definitely agree. So there has been improvement, but I think there are still much room to further improve the design and the devices.
Okay, so we'll have a few more questions. Does the California legislation provide any guidance on the development of a patient mobility assessment tool with a purpose to identify the most appropriate piece of equipment or technique so that it is safe for caregiver and patient?
So that information is available from many the resources. The government does not provide, but I think OSHA also published some document on guidance, and also there are many the safe patient handling related groups. They published some white paper and some documents to include that information. So definitely that information is available.
Great. Also, the director of LOHP, Labor Occupational Health Program, Laura Stock, wrote that the legislation resulted in a Cal OSHA standard enforced by Cal OSHA. So one more question. Are there any consequences for hospital non-compliance with the legislation?
So I think I didn't look at the Cal OSHA citation report, but I think there, especially in the beginning, there were some hospitals cited for not complying with this regulation. So I think there will be more report on the non-compliance.
Okay, and it seems like the questions are dwindling down now, so if anybody has any last minute questions, please feel free to write them in. We do have someone asked if any specific studies have been done on any specific lifting devices.
Oh, can you repeat the question?
Yes. So have any specific studies been done on specific lifting devices?
So many literature, they compared floor lifts and ceiling lifts. There are many studies comparing ceiling lifts and floor-based lifts. And so the many information support the ceiling lifts have more benefits to reduce the injury. But I'm not sure about specific brand or specific the lifts. But in general, they group floor-based lifts or the ceiling lifts.
Hi, are you there?
Yes.
Okay, great. I was just making sure. Okay, and so the very last question that I have for today, before we go ahead and let everyone go, is a statement and a question. So the participant wrote that they understand that literature identifies that successful lift teams require a multifactorial approach. With the legislation requiring them, as someone outside of California, they're interested in how this is enforced, given that not all organizations may be able to adopt a multifactorial equipment investment, needs assessment, training, emergent scenarios, etc. How does the enforcement of this legislation account for these smaller organizations with limited resources?
I think in the California legislation, I mean, they mentioned about lifted teams, but I think the lifted teams or the support staff. So I think so the provision of lifted teams is not mandated. So they can provide support staff to assist the lifting tasks. But as we found in the study, so there is some challenges in having difficulty with support staff. So I think there is a regulation and legislation, and then so it's the responsibility for employers to the maintain or implement effective the programs, and the government have some limitations to enforce the legislation in all the hospitals, of all facilities in California. So definitely, there is need to ensure these effective, safe patient handling programs should be in place in all facilities. But definitely there is some limitation in the implementation.
Thank you so much. And we did have one last question that seemed pretty important. Do nurses' unions help with any of the training and awareness?
So definitely the nurses' union, the CNA, they made a huge effort. Actually, the passage of this safe patient handling law, so CNA was behind in this passage. And also the CNA and also the LOHP, Labor of Occupational Health Program. So they provide the training to the workers. So there are many other groups made effort to provide training and also increase training and awareness.
Okay, thank you so much. And again, I just wanted to thank everybody for coming today and participating in the webinar. It's always a pleasure to have you here. I did want to remind everyone, sorry, give me one second. I wanted to remind everybody that an email will be sent out tomorrow afternoon with the webinar recording and resource links for all who logged in with their registration emails today. I want to thank Dr. Lee for presenting with us, and make sure you check out our website for more information at coeh.berkeley.edu/about-CE. Thank you again for all of your wonderful questions and participation. Everyone have a great rest of your day.
Thank you.
Thank you.